In the first Echo series, we wanted to cover much of the didactics related to post-viral syndromes, ME/CFS, long COVID, and the comorbidities associated with that. And so when we asked ourselves, how can we expand on that and help with clinical care, it brought me back to all the requests that I've received to have people shadow and work with me while I'm actually seeing patients. And even when you have all of the didactic information there, applying it to a patient case, figuring out how to tweak it to really get to where you need to go is sort of a different skill set. And so the goal with this Echo was to try to bring some cases, not to necessarily make it like a grand rounds where we dive into every single detail, but to highlight a few challenges that we come up against here and there and how we generally try to tackle them. So some examples of times where we had to get a little creative or tweak things to get around problems. And we're hoping that that provides some memories and some guidance for people when actually taking care of these patients in their own office. So that is really the spirit in which we created this Echo today. All right. And so for today, we kind of tried to group these into slightly different general vicinity of topics. And today we wanted to talk a little bit about when the aspects of dysautonomia are playing a major role in driving illness and how you can think about managing dysautonomia to actually help with things that may not seem like they're part of dysautonomia in the first place. So I'd first like to start with case number one, which is a case of hypertensive urgency and a patient with psychogenic non-epileptic seizure. So very briefly, we have a 49-year-old female patient who came in for evaluation of significant fatigue, seizure episodes, hypertensive urgency, and concerns for ME/CFS at our clinic. Her fatigue began a long time ago, back in 2015, but she really started becoming functionally impaired instead of after a particular illness that we can record after an extended large family reunion in 2016. She had like something like 50 people at the reunion she was planning, and she never really recovered after crashing from that event. Her fatigue was accompanied by upright activity intolerance and gradual inability to walk more than a few steps in a room without needing to sit down. And that was because she felt weakness and sort of a pre-syncopal feeling. It was a combination of both of those feelings. And she actually ended up, her primary care physician gave her a motorized wheelchair. To be brief, neurological workup to date before she came to our office had been unremarkable for any clear neurological or neuromuscular pathology to explain that weakness. She reported 22 quote unquote good days per month. These were her baseline function days where she could approximate maybe 4 hours of upright activity with her her feet on the floor, sitting or standing. Most of the time that was sitting. On those days, she could read, sew, crochet, use a computer, have a conversation, dress herself or eat, but could not stand in one place for more than 2 to 3 minutes. She was actually requiring assistance in the shower or using a shower chair. She could not walk more than a few steps around her own bedroom or around the kitchen. And then she had 8 sort of bad days, or what we thought were post-exertional malaise days per month, where she had actually less than 1 hour of upright activity. She could still listen to audiobooks with her eyes closed. She could watch videos. She could eat and use the restroom, but she could not prepare a meal, read, dress, bathe, or use her hands for fine motor movements. She loved to crochet and sew, and really couldn't perform any activities out of bed. She had difficulty falling asleep, often feeling excessively wired when she was most exhausted, and her sleep was fragmented with frequent awakenings and often had kind of vivid, stressful dreams or even straight up nightmares. She also had this history of diffuse upper and lower abdominal pain, generally worse after eating. She had associated early satiety, bloating, belching, nausea, but no emesis, and intermittent constipation. Her abdominal pain would be immediately exacerbated after taking medications from many different pharmacological classes. So it didn't seem to be necessarily related to the pharmacology of those meds. And she had general diffuse tenderness over the abdominal wall to palpation and to touch, and she could not wear tight clothing or high-waisted pants as a result of that discomfort. She would frequently present to medical offices with hypertensive urgency with blood pressures in the approximate 190s over 130s. But she always said, hey, when I'm at home laying down, my blood pressures tend to be 150 over 90. They're not as bad. And so she argued that she had severe white coat syndrome. She had no history of stroke, TIA, related headaches, or visual changes that we could associate with these high blood pressures. And she'd actually been unable to tolerate various antihypertensives due to the abdominal discomfort she had after taking pills. She also noted some lightheadedness and dizziness or increasing fatigue and weakness with several antihypertensives in the past. And then she had these continued or repeated episodes or spells that we were referring to as seizure that began back in October of 2017. They would begin with shaking and trembling, but they didn't have true tonic-clonic movements, according to observers. There was no tongue biting, there was no urinary incontinence. She would become unresponsive during these episodes, but she could remember the events nonetheless, and she could actually feel pain even if she couldn't respond. After she would come out of the episode, as she described it, there was this sort of post-ictal confusion and recovery period that could vary in duration. The duration of the whole episode would last anywhere from several minutes up to 6 hours, but more often than not, it was about an hour in duration. And she noticed that these episodes would occur most frequently when she was very fatigued, worn out, exhausted, or stressed, often much more at the end of the day, or sometimes even at night. She'd get up to go to the restroom, and this would trigger one of these episodes. She was observed in an epilepsy monitoring unit for 2.5 days, 2.5 days. EEG did not show evidence for epileptiform activity. And again, they didn't think her movements were tonic and clonic in nature. She showed no improvement after a trial of cognitive behavioral therapy that was recommended at that time, but partially struggled with that because it was difficult for her to maintain concentration on the actual CBT exercises. To this point, her episodes were still occurring daily, and sometimes she would have more than one episode per day. Her past medical history included left ventricular hypertrophy, mild, the hypertensive urgency we talked about, the PNES. She had had Romano-Ward syndrome, which is a prolonged QT syndrome with frequent PVCs. She had been seen by cardiac electrophysiology and had an ablation for this that was thought to be improved. She had the chronic abdominal pain and the label everyone gets, IBS. She had also been told at one point, because of her psychogenic non-epileptic seizures, that she had conversion disorder. She had recurrent herpes simplex labialis, generalized anxiety disorder, mild obstructive sleep apnea on CPAP, hyperlipidemia, and she had had both a cholecystectomy and appendectomy and continued to have this abdominal pain. Was really on barely any medications, as you can see, because she just couldn't tolerate much, but had previously been unable to tolerate lisinopril due to abdominal pain, amlodipine. She felt fatigued and weak on this. Verapamil gave her palpitations and dizziness. And you could see amitriptyline, tramadol, sertraline, and promethazine were all not tolerated for other reasons. So she's really not coming to us on much of anything at that point. These are some measures here, some questionnaires to look at orthostatic intolerance. If she had a pretty remarkable score, anything really over about 30 over 100 is pretty remarkable for notable clinical orthostatic intolerance, and she scored at 73 there. Interestingly enough, despite the diagnoses that she carried, when you look at the hospital anxiety and depression scale questionnaires, she did not score remarkable for either anxiety or depression, which is very different than what you might see looking at that initial presentation. We also had her fill out an SF-36, and here, of course, the scale where is the scale where lower scores equal more severe impairment. And if you kind of look through this scale here, she has pretty severe impairment with bodily pain, general health, fatigue, social functioning, physical functioning, but really not having much problems in the way of emotional well-being or role limitation due to emotional problems. Again, a little bit surprising given her history. On physical exam, the notables are that she had a pulse of 104, blood pressure of 200 over 140 in our office, was sitting in her motorized wheelchair, had quite dilated pupils, even though the room was pretty dark on exam. I'd say almost 9mm pupils, bilaterally symmetrical. Obviously tachycardic, but a normal cardiovascular and pulmonary exam there. Diffuse tenderness to light palpation throughout the entire abdomen, but there was no organomegaly, no masses, normal bowel sounds, no guarding. Her abdomen was soft. She had what would appear to be pitting edema to the mid-tibias bilaterally and very delayed capillary refill in both the toes and the fingers, notably so, and almost a little bit of cyanotic duskiness in all the distal extremities. She had no rashes at that point, did have tenderness to 17 out of 18 fibromyalgia tender points on exam. Her Beighton score for hypermobility was only 2 out of 9. She had hypermobility in the elbows only. Her strength was, despite the weakness reported, 5 of 5 throughout the proximal and distal musculature, normal deep tendon reflexes throughout, but she did have some loss of vibratory sense in the fifth digits bilaterally of the lower extremities, otherwise a pretty normal neuro exam. We performed a 10-minute standing NASA lean test for her, and you can see that hypertension that she started with and a pulse of 96 to begin with. Pulse immediately shot up to 134 and remained in the 120 range throughout. And you can see that even though her systolic blood pressure couldn't rise, her diastolic pressures rose another 20 beats per minute here. She felt, or I should say that about 2 minutes into the NASA lean, her right arm started having kind of a beating motion to it, and her legs became shaky and lightheaded. She had cyanosis of the hands and feet, felt weak by minute 4, said she couldn't stand much longer, and by minute 5, said she was unable to continue and kind of slid down the wall assisted onto the floor. So the test was aborted at that time. And she said, this is what I feel like right before I go into one of my seizure events. So briefly, her laboratory data was pretty unremarkable. Normal CBC, normal CMP, normal thyroid function. Vitamin B12 was 445 with a methylmalonic acid of 178. Iron studies maybe a little low, but nothing terribly remarkable. She had low inflammatory markers, normal CPK or muscle enzymes. ANCA was negative. They were thinking about mononeuritis multiplex there. She did have a negative workup for EBV antibodies, not always what we see in our post-viral syndrome patients. HIV and Lyme were negative. With that hypertensive urgency, underwent a complete pheochromocytoma workup, which was unremarkable, normal ACTH and cortisol, and actually normal serum tryptase, which we all know is very specific for mast cell activation, but not very sensitive, right? A negative doesn't rule anything out. MRI brain showed chronic small vessel ischemic change, but no other major findings. She had a normal EMG NCS of the lower extremities, no renal artery stenosis on her CT angio of the abdomen and pelvis. MR enterography showed a normal small bowel and colon without stricture, fistula, obstruction, or mass. EGD, colonoscopy, and capsule endoscopy were all pretty unremarkable, except for some colonic diverticula. An echo showed mild to moderate concentric LVH with an EF of 54%, mild left atrial enlargement, but no valvular disease, pericardial effusion, no trouble with the aorta. CTA chest was normal. She did have autonomic reflex studies where her blood pressure response to tilt showed hypertension, much like we saw in our NASA lean test. Her QSART responses were normal, and her heart rate response to deep breathing and to Valsalva could not be interpreted because her heart rate was irregular at that time. That was indeed prior to her cardiac ablation. And then, of course, in the electrophysiology lab, she had PVCs that were status post-ablation, but otherwise pretty unremarkable there as well. So she was in our office found to meet 2015 Institute of Medicine criteria for ME/CFS. She had functional impairment greater than 6 months with associated fatigue, post-exertional malaise, unrefreshing sleep, cognitive dysfunction that waxed and waned with brain fog and attentional deficit, intolerance, both from the perspective of POTS, from her orthostatic intolerance questionnaires, and what we would probably define in this case as orthostatic hypertension. So what did we do for her? Our initial interventions were to decrease this excessive sympathetic response to physiological stressors and to try to reduce her blood pressure at the same time. And that's why we chose clonidine, 0.1 milligrams POBID to start. Of course, this is a blood pressure dampening medicine, but the real idea here was to use the benefits of the alpha blockade to try to reduce sympathetic signaling. We also wanted to start to treat her orthostatic intolerance despite these blood pressure issues, and very carefully, very slowly introduce things while observing the response of her vital signs, right? A lot of treatments you would give for orthostatic intolerance would theoretically increase the blood pressure further, so we wanted to be very careful with that. We started by having her wear compression clothing, and she tolerated this pretty well, except on her abdomen where she had that tenderness. We increased gradually her oral free water intake and then her sodium intake. She did so by using packets of liquid IV electrolyte solution. And we eventually started her on some low dose pyridostigmine that she would take in the morning, 4 hours later, and then 4 hours after that, 3 times a day. That eventually was able to be titrated up to a full 60 milligram tablet 3 times a day. And what happened with that? Well, She actually said it's easier to fall asleep and stay asleep. She wasn't having as many vivid dreams or nightmares, which we attributed to the effects of the clonidine. She had reduced incidence of her seizure spells. They were only happening, she only had 4 in the total of 4 weeks after getting on all of these interventions. The duration of her spells also was reduced from about 60 minutes to 20 minutes. And she was recovering quicker with less of that post-ictal, if you will, confusion after the spell was over. Her functional status was improving. She could actually start crocheting from bed again. She was ambulating around her bedroom more and around the house more. She could ambulate down to dinner. Her blood pressure at home, or sorry, in the office remained at 192 over 136. But actually at home, when she was measuring her blood pressures, her average blood pressures, again taken supine, were in the 130s to 80s as compared to the previous 150s over 90s. And she did not actually, surprisingly, have any worsening of her abdominal pain with these initial interventions. It almost seemed like treating the orthostatic intolerance may have been leading to better abdominal perfusion and reduced pain. She did have a clinical setback where she caught an infectious gastroenteritis from her husband and her son, and that led to significant nausea and vomiting, as well as increased abdominal cramping and pain. She was unable to keep up with her oral fluid and sodium intake and could not take her medication, so this led to a pretty significant setback with her fatigue and weakness. She couldn't leave her bed except for trips to the bathroom, and she again returned to frequent seizure spells. Blood pressures at that time one was recorded at 194 over 126. So what did we do? Despite the fact that it seemed a little risky at the time, we did think it was the right thing to do to give her some IV normal saline due to the decreased PO intake, and she got 3 days in a row of IV normal saline at 1.5 liters. We were, of course, monitoring her blood pressure carefully during that time. And her response to that was positive. Her weakness, fatigue, abdominal pain all improved with fluid repletion. And actually, her blood pressures modestly decreased with fluids rather than increased. And then she was finally able to start reintroducing oral clonidine and pyridostigmine after the IV fluids. Further clinical strategy from that point, we wanted to continue to work to decrease her sympathetic response to the physiological stressors of dysautonomia and orthostatic intolerance. Her clonidine was titrated upwards to 0.2 milligrams in the day and 0.3 at night. We did at one point, I think, try to go up to 0.3 in the day, but that made her a little sleepy. We also added 20 milligrams of propranolol at night, which was helping her to fall asleep and avoid nightmares or frequent nighttime awakenings where she would feel wired and alert without clear cause there. And then we also wanted to continue to push the management of her orthostatic intolerance. We added 0.1 milligrams of fludrocortisone, which we were, of course, reticent to do at the beginning with those blood pressures. We increased her pyridostigmine to 120 milligrams PO 3 times a day and increased the overall sodium she was taking in. So she increased the number of liquid IV packets she was using. After that, we noted that she only had 2 seizure spells over the subsequent 6 weeks, and both of those seizure spells were less than 10 minutes in duration. She was able to walk around her house without her wheelchair and only used her wheelchair when leaving home. When she did see us 6 weeks later in the office, her blood pressure was 130 over 78 with these interventions, and her postprandial abdominal pain and cramping was again partially improved. She was, however, concerned that she was having increasing pain and redness in the bilateral feet and sometimes in the hands. And so she was concerned that she was having peripheral edema from all the fluid and salt and maybe from the fludrocortisone. And that's certainly a consideration we had. However, on my exam and the way she was describing it, I was actually more concerned for a erythromelalgia-like presentation with vasodilation, warmth, and swelling in the hands and feet. And in fact, we attempted to identify this and or treat it by introducing very low dose midodrine, a peripheral vasoconstrictor, which actually relieved these episodes in her hands and feet. So she started at 2.5 milligrams 3 times a day and then went up to 5 milligrams 3 times a day. Again, very careful monitoring the blood pressure as we slowly introduce these things. As far as reducing her sympathetic response further, she began working with the Dynamic Neural Retraining System, or DNRS program. The idea of this program, as it's marketed, is that this is a limbic retraining program, but I think the way we went into it was understanding that the exercises that are taught in this program really appear to help people gain some conscious control over their otherwise autonomic nervous system sympathetic responses. So it's really kind of a way of taking control of heart rate, of blood pressure, of how you experience symptoms, almost like a biofeedback type of mechanism. She was also started on very low dose aripiprazole in an attempt to decrease sensory sensitivities because she had still been noting light sensitivity, sound sensitivity, and feeling overwhelmed in large groups, which for her was often big family gatherings. And, you know, when she would feel sensory sensitivities, this would trigger her sympathetic symptoms. And the clinical improvement we saw with that were reductions in those episodes of pain, swelling, and redness and warmth in her distal extremities. It did appear that it was indeed erythromelalgia rather than just peripheral edema. Blood pressure remained low in the office, and she did not have a single seizure episode for the subsequent 3 months. She was only using her motorized wheelchair when leaving the house, but would ambulate around church as well when she would leave her home unassisted. And she had significantly reduced postprandial abdominal pain and reduced early satiety, bloating, and nausea, which we thought might have been related to improved perfusion of the gut. So the kind of major points we wanted to emphasize here is that in this case, her psychogenic non-epileptic seizures may have indeed been related to inadequate cerebral perfusion in the context of poorly controlled dysautonomia. Furthermore, her uncontrolled dysautonomia appeared to lead to profound sympathetic hypertensive responses, and those responses improved with the same type of treatments we would have used for an orthostatic hypotension. So that is case number 1, and I'd love to pass it over to Jenny Bell.
That's great. Dr. Yeoman's case is going to sort of has highlighted some things I'll be talking about in mine as well. So I brought this case up because I felt this case really highlights how anxiety can be the presenting symptom of dysautonomia. So this is a 20-year-old male who presented in our clinic at the beginning of February, and his primary complaints at that time were chronic fatigue, brain fog, anxiety, and insomnia. And he had concerns about medications he had been put on. He no longer was able to live on his own, and it was hard to hold down a job. He had graduated from high school a little after his initial illness with this, and he had been able to move out of his home and live on his own, and was working as a software designer in a small firm. And he finally got to the point to where he couldn't do that anymore and had to move back home and quit his job, which was very upsetting for him at 20 years old. So his initial infection was November of 2019. He was a senior in high school. His complaints of fatigue, nausea, vomiting, chest and nasal congestion, shortness of breath, chest tightness, and body aches. He didn't have any loss of taste or smell. He was sick for 4 to 5 days and then was back to normal in about a week. His entire workplace was also sick with similar symptoms. 2 to 3 weeks later, he had a return of the fatigue, but new onset insomnia and panic attacks, particularly when he was driving. He was having difficulty driving from school to home and work to home and school, and just was starting to have a big impact on his daily life. He would sometimes wake up in the night with panic attacks, and his smartwatch would indicate that his heart rate was 180. He's a thin guy, he wasn't super athletic or anything, but he was thin, he wasn't overweight in any way. In summer 2020, he had decrease in physical and cognitive stamina. That's when he really noticed how much he had lost, and he continued to have worsening fatigue and anxiety. And over the next 3 years, he sought care with primary care and psychiatry, but his symptoms didn't really improve. He had no known COVID infection, and he was vaccinated with the two-dose bivalent vaccine, and then has had a couple boosters as well. Prior medical history was pretty low or minimal. He did have ADHD diagnosed in grade school, but wasn't on medications for it. He had some anxiety and depression that was intermittent and successfully treated with periodic fluoxetine and an occasional lorazepam, like 1 or 2 times in a year. Had some allergies, a little bit of heartburn. The medications he came to me on were fluoxetine, 20 milligrams, zolpidem, 10 milligrams at night, lorazepam, 1 milligram, but taken 1 to 2 times a day, and melatonin was marginally helpful. He was really concerned about being on zolpidem, lorazepam. That was his primary issue. He said, I want to get off these medications. He had tried a number of times on his own over the last 3 years, and every time he just felt so much worse. So when he came into our office for his physical exams, I did a full physical exam, neuro exam, cardiovascular exam, et cetera, and everything was quite normal. But the main thing that really jumped out at me was that he looked like he was about to jump out of his skin. He was incredibly tense, anxious, pupils were dilated, sweaty. His heart rate sitting while I was examining his heart and lungs was 130. His seated vital sign when he came into the clinic was 130 over 98 and a heart rate of 105. So that was technically at rest. Dr. Yeoman already mentioned that we do a 10-minute NASA test, or a passive standing test in our office, which is primarily where we have patients lie down for about 15 minutes in a dark, quiet room to sort of settle the nervous system down. Then we do heart rate and blood pressure readings while they're lying down. Then they stand up for about 10 minutes. We have them leaned against the wall at a slight angle where their shoulders are against the wall and their feet are about 6 inches from the wall, and the rest of their body is not touching the wall. We're removing any skeletal muscle assistance in standing, so we're getting a better look at what the vascular and neurologic system is doing. And he had a pretty profound lean test. He didn't have the blood pressure rise like Dr. Yeoman's, but this was still pretty significant. So his heart rate, which I'll point out first, jumped, well, it was lying down, he was 101, but his heart rate jumped to 134 during the test. His supine blood pressures were pretty normal, actually, but as soon as he stood up, his diastolic started to go up quite a bit, with an increase of 40 millimeters of mercury total in the 7 minutes that he stood. The systolic increased by 28 millimeters of mercury. This in turn reduced his pulse pressure, and we divided by systolic blood pressure for a percentage, and a normal pulse pressure should be above 25%. But lying down, his pulse pressure divided by systolic blood pressure was normal. As soon as he stood up, his pulse pressure started to decrease and he got down into the teens, and which suggested that he was getting less and less cardiac output. Symptomatically, he was becoming increasingly miserable while standing there, mottled hands, mottled feet. His pupils were further dilated, shaking, sweating, increasing sound and light sensitivity. He just was, everything was sort of going haywire, and we had to stop the test about after the 7th minute testing because he didn't think he could stand there anymore. The modeling was pretty impressive. His modeling of his hands and feet were going up, were almost up to his elbows and his knees. So this test was diagnostic for POTS, as he had an elevation of over 30 beats per minute, but he also was over 120 beats per minute in total. He had what I call a hypertensive response to standing. So that is not technically hypertensive in the, like an essential hypertension, but when he stands up, this is what his body is doing, which is why he was having trouble sitting at a desk during the day and could no longer function and take care of himself in his own home. He was most comfortable lying down because his body, when he stood, was becoming very dysregulated. Diagnostic findings, yes, there are a few abnormal findings, but none of them were really pertinent to his dysautonomia. Probably a little bit of a hydration issue here with slightly high elevated RBCs and hemoglobin. These would bounce in and out of normal looking back at his last prior blood work. He did have a high calcium and a low vitamin D, but this started to correct when I supplemented with vitamin D, and his calcium is coming down. I'm rechecking that now. He does have some allergies, it appears, but tryptase is normal. He does have a history of having had EBV, but there's no evidence of active illness, and it's hard to know whether he had a reactivation. The rest of his lab work was normal. I won't go through these. Immunoglobulin panel was negative. I did get an echocardiogram, which was normal. He had a PSG prior to seeing me and a tiny bit of very, very, very mild obstructive sleep apnea. His rheumatologic screen was negative. So diagnosis from his first visit was post-viral syndrome. He did meet the 2015 ILM criteria for ME/CFS, which Dr. Yeoman outlined in his talk. Unknown viral trigger, maybe influenza, maybe EBV. And I know I'm really stretching if I say could have been an early SARS-CoV-2, but that's all in our brains these days. Dysautonomia and POTS, as I've already mentioned. What was really interesting was the amount of venous pooling he had, which we definitely indicated that he was not able to get that blood back up into the core in the brain, which is probably what was driving his dysautonomic response and fight or flight response. So my next very easy thought was that this is probably what's driving his anxiety and insomnia. This dysautonomia is it driving all of it 100%? Maybe not, but it's certainly driving a lot of it. His cognitive impairment, which was significant and making it very difficult for him to work, was probably secondary to poor brain fusion from low cardiac output. Maybe some neuroinflammation from whatever illness he got. So I kind of broke this down into how I've been working with him over the last 6 to 8 months into 2 phases. So phase 1, which is the first 3 to 4 months of working with him. So initially, right away, I increased his vascular volume by adding a significant amount of oral hydration and sodium. So basically 3 to 4 liters of water with 3 to 4 grams of sodium per day. Which improved his brain fog and his fatigue somewhat, brought his anxiety down by a noticeable amount, but it was still pretty high. I also did a course of IV fluids, like 1 liter every other day for 2 weeks to see how much that would help him. And it did improve his anxiety and upright tolerance, and it created a bridge for us for adding some other medications on. It's not the staple of his treatment, but something that we've used a couple times over the last few months when he's not felt well. At that first visit, I also started on propranolol, 10 milligrams TID, which lowered his heart rate, stabilized his blood pressure, so he wasn't having such a high increase in blood pressure when he stood up. It improved his sleep somewhat, but his anxiety and insomnia was still there. I knew that I really couldn't address the zolpidem or lorazepam until I got the dysautonomia under control. Then I might be able to start pulling off those 2 drugs. So that's my focus, to see if I could get the POTS under control. So a couple of visits later, I tried him on some clonidine, 0.1 milligrams. And he had questionable benefit. We weren't quite sure how much it was working, but I kept him on it for a little bit. And then he was really willing to take on compression clothing. So he put on his compression leggings, compressed his legs and abdomen, and that made a huge difference when he stood up. His standing heart rate would drop, and he had much better upright tolerance. He also was tried to be careful to not overexert. And so was pacing carefully and trying to minimize going into post-exertion malaise. So these were the biggest changes in that first phase of improved physical stamina, fatigue, improved anxiety and insomnia, decreased tachycardia, and improving cognition. But we weren't there yet. So phase 2, I started to think about, okay, we're making headway. How am I going to get him off these 2 meds? So I thought, well, okay, I'll try him on some propranolol XR to see if we can get better 24-hour nighttime coverage to bring down that sympathetic drive. And unfortunately, he did not tolerate it and worsened his grogginess and worsened brain fog. At the same time, when I put him on the propranolol, I stopped the clonidine, and he didn't feel good going over that. And that's when I got a sense of how well he was doing with the clonidine. I put him back on a clonidine pill at that time, and we went back to the propranolol 10 milligrams 3 times a day. And this seemed to stabilize him pretty well. Then I initiated some dextromethorphan, 15 milligrams twice a day. We've seen a lot in our patients that this can be a subtle but important little tool to reduce some sympathetic overdrive and increase their resilience to activity. His cognition being such an issue, I also decided to start low-dose aripiprazole. And as Dr. Yeoman said, one of the reasons I chose this was also sensory sensitivities. He had a lot of sensitivity to light and sound, which was really impacting him, and it was exhausting to him to have any kind of noise around him. So we normally start 0.5 milligrams and work up to 2 milligrams. He was able to titrate up to 2 milligrams very well, and that made a big difference in his cognition and anxiety. It also improved his sleep. And then thinking about, okay, we're improving his sleep, now I got to figure out how to get that the anxiety under better control. I started adding some hydroxyzine at night, playing between 25 and 50 milligrams, depending on what was going on. We continued the non-pharmacological interventions as we were doing these changes. So where are we now with his controlled substances? I met with him actually on Monday, which was good timing. In July, he had stopped his Zolpidem. So he had been able to get off of that totally. So I felt reducing his sympathetic overdrive greatly reduced his anxiety symptoms, thus reducing his insomnia. So that was actually quite easy. And lorazepam took a little bit longer. He gotten down to 1 milligram a day by the end of phase 1, and then in phase 2, we were trying to get off of the last of it. And over the last couple of months, he weaned off 1/4 milligram at a time, utilizing his hydroxyzine. He'd go up to 50 milligrams on the days that he would start to drop the next dose, stay on that for a number of days, and then drop it back down to 25 milligrams at night. And that seemed to work to really get him off of it. When I met with him on Monday, he'd been off the lorazepam for a week, had felt really good, but he was starting to have a little of his sympathetic overdrive symptoms coming back in, a little anxiety, a little tachycardia. So on Monday, I switched his clonidine to a patch, a 0.1 milligram patch, with the thought that I might try to add a little more clonidine later on, depending on how this works. He also found that hydroxyzine didn't make him tired at night, tired during the day. So he had used a little bit of that during the day when he felt his anxiety picking up, and that seemed to help bring it down. And he also has propranolol to use on the PRN basis. So right now we're kind of in a transition zone, but he's pretty well regulated. So what does this mean all functionally mean? Right now, he's able to sit up all day and work at his computer. He's not working, but he's wanting to maybe take a full-time job working from home. He'd been working with a software design app and could manage it all day and have energy and not crash after doing that all day. He's able to drive for 30 minutes and do low-impact errands. He can go to Walmart, he can go to the grocery store and deal with all the things that are coming at you from a sensory standpoint. He was able to go bowling with friends the other day, which he said he wouldn't have been able to do. He hasn't been able to do for 3 years. And because he's been not doing much for the last 3 years, I'm mindful of the fact that he hasn't had any kind of exercise and conditioning. So I'm going to send him to PT to get some careful reconditioning. Careful being that I don't want him to have his post-exertional malaise exacerbated. PT can be a great thing or a really hard thing on these patients, because if it exacerbates their post-exertional malaise, it can make them worse again. So I'll be referring him to a physical therapist who understands about PEM. And I'm just very, very pleased with where he is right now. We're by no means done with determining his therapy. But we've made a lot of good headway. He's also been a patient who's really owned what he needs to do and has been very proactive. But I really felt this case really highlighted the importance of not jumping to a psychological cause for the anxiety and insomnia, but maybe this is a dysautonomia, and utilizing a really simple test like the Massillon test or a Pasolini test in your office can give you so much information to where it could really help you determine whether dysautonomia is a big player in your patient's symptoms. And that's all I have. Thank you.
Jen and Dr. Yeoman, those were great. I think we have enough time to get through Dr. Yeoman's third case, and then we'll field some of the questions from the chat box. Just as a reminder, feel free to use that chat box to start entering in those questions, and we'll ping them right after Dr. Yeoman's third case here.
So this last case we'll go through quickly. It's more of a vignette to talk about some uncontrolled mast cell activation syndrome. Click over here to make the slides advance. So we had a 33-year-old female who was chronically seen in our office. She'd already been diagnosed with ME/CFS, HEDS, POTS, and orthostatic intolerance via the 10-minute Massillon test, small fiber polyneuropathy, ADHD, and mast cell activation syndrome. And that was actually because of a serum tryptase that was elevated. And she presented to our clinic in follow-up with worsening diarrhea, worsening abdominal pain, rashes, facial flushing, itching, and rhinosinusitis. Her rashes were occurring on the trunk, arms, and legs and were very itchy. They could be present from anywhere from 1 to 12 hours, then would fade, while new ones would appear more prominent in other locations. So this kind of migratory changing rash. The rashes were similar in quality to previous mast cell activation rashes before initiation of mast cell activation treatment, of which she was on. We'll come to that. Her loose stool was associated with stool urgency and 6 bowel movements per day, often immediately after eating with urgency. She also had postprandial abdominal discomfort to most foods and to her usual oral medications that she previously tolerated. And she was recognizing stuffy nose and sinuses with mild frontal sinus headache and some difficulty sleeping due to that congestion and its effect on her breathing. There were no recent clear environmental allergy exposures, such as food allergies, a new detergent or soap, new medications, new jewelry, chemical exposures, etc. She had had no recent episodes of post-exertional malaise, which we all know can certainly exacerbate any of one's symptoms of post-viral illness. She was afebrile with a blood pressure of 98/60, which is a little lower than her usual 110/70, pulse of 92. At rest, respirations 12, SpO2 97%, and she had normal basic labs. She was seen by dermatology before coming into our office. They did not choose to do a skin biopsy given the migratory nature of her rash, and they gave her topical triamcinolone cream, which gave her mild relief of itching at the location she put it on, but doesn't really do anything for the fact that she kept having new rashes emerge all over her skin. Her current mast cell activation therapy was actually pretty aggressive at that point. She was already on a half of a vial or 50 milligrams of Gastrocrom liquid cromolyn. She'd take that 15 minutes before she'd take medications or eat meals. She was on a compounded capsule of cromolyn as well, 200 milligrams 3 times a day, 1 milligram of ketotifen twice a day. She was on montelukast, fexofenadine, famotidine, and would still use diphenhydramine as needed, and was still having breakthrough symptoms at this point. These were some of the types of rashes she was having despite that active regimen against her mast cell activation. She had additionally been noticing some increasing dyspnea with exertion, some palpitations going upstairs, dizziness upon standing or when she'd remain upright. She was noting more exhaustion and feeling unwell when taking showers, had a decreased appetite, and was noting more temperature intolerance. Of course, the season was shifting to summer weather at that time, and it was starting to get hot outside. Here in Utah, we have many homes that may not have central AC, but just have a swamp cooler, and it doesn't always keep up with that heat. She admitted to also being a little less stringent about her oral fluid and sodium intake than she had in the past, and she was not using her compression stockings anymore, one, because it was a little too hot, and also because it seemed to, when she would take them off, contribute to like a vasodilatory redness in her legs with associated itching after she had left them on. Her current orthostatic intolerance and POTS therapy included oral free water and liquid IV for sodium supplementation. She was on fludrocortisone, 60 milligrams of pyridostigmine 3 times a day, some low dose midodrine, but that had been dose limited because as she increased the dose, she noticed scalp itching and some funny paresthesias in her skin. And she was also taking 25 milligrams of atenolol twice a day. So what did we do for her? We actually said, you know, it seems like she's having orthostatic intolerance symptoms also flaring with the mast cell, and there's not all that much we can do from a mast cell perspective pharmacologically to begin with, maybe a little bit, but we wanted to sort of look at, can we improve the mast cell activation by improving the dysautonomia? So she was actually switched from her short-acting pyridostigmine to extended release pyridostigmine, and then that was titrated upwards from 1 tablet or 180 milligrams, which is more or less the equivalent dose of her 63 times a day. We went up to 1.5 tablets of the pyridostigmine ER. And 2 things I'd point out with this: the ER formulation is often a great way to get around side effects with the short acting, including loose stool and muscle fasciculations you might see. And also, even though we're always taught to never ever cut an extended release formulation, for whatever reason, our patients have been doing it for years, and it does not seem to reduce the extended release benefits. So going up to 1.5 was a functional dose increase that still allowed her that reduction in side effects. We also discontinued her midodrine, given that dose limited nature. Would have loved to have a much higher dose, even though it was clear that the mechanism worked, and actually switched it out with its, I like to call it a cousin, droxidopa. Put her on 100 milligrams 3 times a day, and then gradually increase that to 200 milligrams 3 times a day. So the point I'd bring up here is that droxidopa is often much better tolerated than midodrine when you do have sensory neurological side effects with the midodrine itself. Got her back onto a more stringent oral fluid and sodium intake regimen. And then for mast cell specifically, we increased her Gastrocrom dose a little bit from the half a vial to a full 5 ml vial or 100 milligrams before meals and medications. And then gave her a quick little burst of prednisone, 10 milligrams times 3 days and 5 milligrams for another 5 days, just to try to calm things down. And with that intervention, her rash outbreaks resolved. The itching in the skin was minimal, although she would occasionally use some as needed diphenhydramine for itching after a shower or maybe one time a week. Otherwise, stool formation improved. Stools were reduced to 1 to 2 times per day. Only 1 to 2 episodes of postprandial discomfort per week, which was pretty consistent with her baseline. Rhinosinusitis cleared up. She could breathe better when she was sleeping, less dyspnea on exertion, less palpitations. Her fatigue improved, her exercise capacity improved. She could go up the stairs without feeling like it was a struggle. And her blood pressures kind of came back to her normal baseline and was read at 112/74 with a reduced pulse rate down to 76. So I wanted to just point out here that the physiological stress of dysautonomia can actually exacerbate other pathologies like mast cell activation syndrome as well. And sometimes when you're button up against what do I do for the mast cell, think about what else is going on and approach those other clinical issues as well. So at that point, we will stop bombarding you with cases and would love to have a discussion.
Dr. Yeoman and Jen, thank you. I think, we're trying to really display who's in the driver's seat, right? Who's driving who. And there's a lot to this in the post-viral world. So we do have a couple questions in the chat. This first one, I'm actually going to ask Clayton to respond to first, and then the rest of our mentors and speakers can chime in. It is around what are clinicians recommending for people with HEDS who have extreme difficulty donning compression leggings, tights due to hand or wrist instability and live alone. Abdominal compression alone doesn't always appear to be adequate. Any options? And I think that's more in line with the orthostatic piece of this presentation. So Clayton, if you wouldn't mind.
And some of the patients who have difficulty donning the compression, if they can afford it, often I'll recommend pneumatic compression devices, these boots that cover the whole lower extremities on both legs. And we usually try them on in the clinic. We have a pneumatic compression device. And so I'll have patients try it and it helps them recover a lot faster. If they're starting to look like they are struggling or experiencing fatigue, we'll try the pneumatic compression along with ice, like around their neck or on the legs, and then usually patients are able to rebound faster. So if they can't afford that, it can be a helpful tool. I've had patients who have POTS tell me, I used to wear compression, but once I got the pneumatic compression, I stopped wearing compression, and now I just use the pneumatic compression whenever I have symptoms. One of my patients, when he's left the clinic, he even brings it with him in the car and can put him on before driving and get that pneumatic compression, get the blood pumped back up to his heart and head, and then he's able to drive and not fatigue as much or experience as much orthostatic intolerance.
Clayton, do you have an idea of what that runs price-wise?
Yeah, they are around $200 to $800, so they're not going to work for everybody, but the patients who get them, I had a patient this week, for example, who said, I used to I'd get done with work or sitting at my desk, and then I'd get home from work and need to go lay down, but I have homework to complete. And so then they would, now I can put on the pneumatic compression and I can sit and do my homework, and I don't have to lay down as much to do my homework.
Do you have a particular brand recommendation?
Not necessarily. The Normatec are good, but they're expensive. I can't really give it specific brands, but just ones that cover the full legs.
Thank you. Dr. Brown or Dr. Yeoman or Jen, do you have anything else you'd like to add on that comment?
I would say that there is a study out of the Vanderbilt Autonomic Center that actually suggests that abdominal compression is in fact more effective than full length lower extremity compression. Obviously they're best when combined, but if you compare the two, abdominal compression actually gets you farther. So for those patients who do struggle to put on really tight compression on their legs, but are at home alone and don't have the type of visceral abdominal hypersensitivity that my case 1 patient had, the abdominal binders can really move the needle. So don't forget that as an option. But yeah, it's not easy to put the compression on and off. And if you're hypermobile and by yourself, and if you're fatigued, it can be quite the ordeal. So it tends to be something that works better when people do have assistance getting those on and off. The other thing people ask me is, do I need to take my compression off every time I lay down to take a nap? And of course, the answer is no. I have them keep it on all day until they're really ready for their full night's sleep.
Yeah, it can almost be a workout getting compression clothing on. Question in the chat here related to anxiety. Do you vary medications depending on the type of POTS, specifically hyper POTS?
I can answer some of that. Yeah, it depends. If you have somebody who's got, I guess I'm guessing that hyperpots, you mean kind of what I showed on my patient, where you have a hypertensive response to standing. You know, I think at that point I would reach for sympathetic overdrive or beta blockers, alpha blockers to start to try to bring that down right away. Whereas if I have somebody who has a high heart rate, but maybe their blood pressure isn't very high, or their heart rate increases slowly as their blood pressure drops, then I might be less inclined to reach for a blood pressure lowering type medication, and might be more aggressive with, well, I'm always pretty aggressive with fluids and sodium, but work to compress with midodrine, pyridostigmine, compression clothing first before adding a beta or alpha blocker. So a lot of it depends on sort of the nuance of when does that heart rate start going up? When does that blood pressure start going up or going down? Can sometimes give you an idea whether you want to be using something that's going to really suppress their blood pressure and or their heart rate. So I hope that's helpful.
And I think the other point I'd add to what you're saying there is essentially that we may use the same medications, but we may employ them in a different order of operations. We may start in a different place, even if we end up in the same place at the end. And I think, you know, buried in that, what's important, if you look at a lot of the dysautonomia literature, there's so much emphasis placed on, is this hyperadrenergic POTS? Is this neurogenic POTS and orthostatic hypotension? Is it POTS at all, or is it just orthostatic hypotension? And I think that we get lost in those details when in reality, what we've seen in our ME/CFS and long COVID studies is there's decreased perfusion of muscle tissue, there's decreased perfusion of the brain tissue. And really, I think what we're seeing are compensatory responses. Different individuals will have different compensatory responses. The same individual will have different compensatory responses over the course of their illness, whether it's the first year of their illness, whether it's 10 years in. And yet the treatments often work the same, no matter what their compensatory response is. We're trying to reduce that initial pathology, which is that dysautonomia-based poor perfusion of other tissues. So that's generally the way I think of it going into it.
The other thing I'd add is when we start talking about anxiety, I mean, this is pertinent to me sitting in the ICU right now, is I have a lot of patients that have pretty distressing symptoms. Like if you're legitimately sick and you have bad shortness of breath, you know, you get scared when you have to do things that you know in your day-to-day life will provoke those symptoms. And so it can trigger, it's not necessarily that they're like baseline anxious people, but they truly have a legitimate response. They're worried they're going to pass out. They're worried that they're going to have this symptom and then it'll be embarrassing. So I think when you start teasing out anxiety, you have to ask, like, what is that fundamentally? And also and I think also some acknowledgement of, yeah, it's really scary. You know, I would be terrified too if I couldn't breathe or didn't feel in control of my body or any of these other symptoms. So I think teasing that out too is important. There was another comment, I think, from like prazosin for PTSD and nightmares. Like pulling some of these things out, I think specifically, especially if there's another factor, like I know people that will be afraid to go to bed, for example, if you keep having nightmares. So some of these things are legitimately an appropriate response to be worried about those things. So I think you kind of got to dig into the anxiety component too.
To comment further on the question, would you consider adding propranolol or clonidine for anxiety, tachycardia, orthostatic intolerance in a patient already on prazosin or on tamsulosin? You got to be careful. I would probably only use one alpha blocker at a time. So I would maybe try both and see if the patient does better with clonidine or prazosin. Sometimes it's one or the other. It just depends. Beta blockers, I would certainly consider in this case, assuming they had the blood pressure and heart rate room to do so. And there's, of course, short-acting beta blockers and long-acting beta blockers. Sometimes a combination of both where we use the short-acting as needed. But we also have other tools that we use in addition to alpha and beta blockers. We talked about the DNRS in my particular case. Vagal maneuvers, vagal nerve stimulators can be helpful. And it's always controversial, and sometimes I hesitate to bring it up, but just my clinical experience has shown that benzodiazepines are incredibly useful in this patient population. And I think that that's partially because, you know, we think of them as a dirty drug. They don't only work at the central nervous system neurotransmitters, they actually work in the periphery. And when you have a dysautonomia, that's actually what you're looking for. So when I get stuck with what I can use on an alpha or beta blockade, they really do come in handy. I've never seen a single post-viral syndrome patient ever have a psychological addiction to them, never. So they are a tool to remember that's still in the tool belt if you really need it to help these people.
Well, that was a perfect way to wrap our discussion today. I do know that there were a couple of other questions in the chat, but I'm hoping that they were able to get answered by one of the mentors. Just as a reminder, claim the CME by midnight tonight, and then we do have an additional quarterly session that we're running. These don't happen, you know, every month, but of course that's why they're quarterly. But that will occur this month on October 19th, where we will be hearing a special presentation from Dr. Knight. He is a hypermobile specialist at the Mayo Clinic, and he'll be talking about hypermobile spectrum disorders in long COVID and ME/CFS. So that is October 19th at 12 p.m. Mountain Time. Same registration link, same connection link. So we hope to see you there. Thank you all for your time today.
I would also really briefly add that our next regular echo is similar to this, only a situation where other comorbid illnesses are making dysautonomia worse. So kind of a mirror to this particular presentation.
Yes. Thank you, Dr. Yeoman. Have a good afternoon.